Thank you very much, sir, for inviting this very nice meeting. So I think this is the third APVIC that I joined so far. Every year, it's been wonderful that you have this organization. So actually, we try to share some developments in the pulmonary hypertension. So it's been several years that there are interventions in chronic pulmonary hypertension, and one of it including CTAP. We call it CTAP, chronic thromboembolic pulmonary hypertension. So pulmonary hypertension is actually defined by right heart cath, where there's an increase in mean pulmonary arterial pressure as equal or more than 25 millimeter mercury. And we have several definitions. Actually, when we can find the pre-capillary or is it post-capillary, and then the pre-capillary, where the CTAP is one of it, is where the MPAP is more than 25, and the pulmonary capillary wedge pressure is less than 15 millimeter mercury. The latest update on clinical classification of pulmonary hypertension is actually it has 5 classifications, and we have worked on several types of these pulmonary hypertensions. Most of them are the type 1 PAH, and some of the type 2 PAH, and less numbers of type 3 and type 4 PAH. So we have the intervention for the type 1, where we can do the shunt closures, as it's already widely established, or the interarterial shunt creations when the pulmonary arterial hypertension or idiopathic PAH occur. And type 2 or PAH due to the left heart disease, what we can do is usually the valve interventions or development of interarterial shunt creations in the heart failure with reserve ejection fraction, or those with diastolic heart failure is being developed. And what we're now trying to have as a learning curve is where we find the CTAP as the type 4 pulmonary hypertension. And we know that CTAP requires 2 criteria, where we find the hemodynamic findings of MPAP more than 25 with pulmonary wedge pressure is less than 15 millimeter mercury. And we have to calculate the pulmonary vascular resistance of equivalent or more than 3 Wood unit by right heart cath. And in these patients, we find the presence of chronic organized thrombus or emboli in pulmonary artery that persists despite at least 3 months of effective anticoagulations. So basically, the mechanism underlying the CTAP is there's a pulmonary stenosis or obstructions because of chronic thromboembolism is considered. So I will not talk a lot about it, that the incidence of CTAP is mostly in those who is confirmed previous acute pulmonary emboli, which is around 75%, is already published before. The natural history of CTAP itself, when patients is survive or the survivor of acute pulmonary emboli, or those who has a silent pulmonary embolism or venous thromboembolism, and they have incomplete resolutions and organizations of the thrombus, which cause the vascular in the pulmonary vascular stenosis or occlusions. And usually the remaining thrombus cause the occlusion or the stenosis in the distal part of pulmonary arteries. And the shear stress that will result in the progressive increase in pulmonary vascular resistance and occur to the distal part of the thrombus. It occurred as a microarteriopathy. And it will develop the symptomatic CTAP itself. So this is more or less the pathophysiology of CTAP, the distal thrombosis of pulmonary artery, who usually will have a partial recanalization in the patients with pulmonary emboli. And part of the thromboembolic material itself will occlude the small part of the branches of the distal pulmonary arteries, or in the segments of the pulmonary arteries itself. And the development of the capillaries will look like the pulmonary arterial hypertension itself by histology examinations. In other part, the bronchial artery will be hypertrophied, and also the pulmonary vein will have remodeling, which mimicking the venular fibrosis in the pulmonary vein occlusion disease or PVOD. So the challenge for us actually in the development country is how to diagnose the C-type itself. So when we have quite numbers of patients with symptoms and signs of pulmonary hypertension, and we already have a very strict criteria for high probability of pulmonary hypertension by echocardiography, where it's established also in the guidelines. And when we exclude the left heart disease, and then unfortunately we don't have VQ scan, so sometimes we perform the CT scans as a replacement of VQ scan, but actually the guidelines you should do the VQ scan to see whether there's a mismatched perfusion defects in the lung. And when you find the mismatched perfusion defect by VQ scan, then here, then you will have the C-type possibility. Then we will have to think about performing the either CT pulmonary angiography or the right heart cath with the selective pulmonary angiography. So more or less, this is the diagnosis for the C-type itself. And the treatment of choice for C-type, once it's the diagnosis is confirmed, that we have to give the lifelong anticoagulation, and we have to see the operability, whether the patient technically operable or the patient is operable or is it not operable. So basically there are three treatment of choice for C-type. The first of the gold standard is the pulmonary arterectomy, and then the medical therapy will be given along with a PEA or the medical therapy itself when it's not suitable for PEA. Or the recent intervention developed by the Japanese groups are balloon pulmonary angioplasty, which is also done with along with a targeted medical therapy. So in pulmonary embolic survivors with remaining dyspnea, so C-type should be considered, and we have to exclude whether this patient is having C-type or not. And pulmonary end arterectomy is still the gold standard. However, when the patient is not ineligible, about 40% of C-type patients are ineligible for PA due to the technical inaccessibility, due to the poor surgical candidate, or whether it's patient choice or the persistent pulmonary hypertension even after the pulmonary end arterectomy. And the treatment decision-making process is when you have a patient with operable and favorable to PE, just do the pulmonary and arterectomy and evaluate the treatment goals. We will explain later the treatment goals. And when it's unfavorable for surgical, then we have to evaluate whether the lesions itself is favorable for BPA or not, along with vasodilator therapy. But when it's not favorable for BPA, then the medical treatment is one of the choice itself. When the treatment goals is achieved, then we have to leave the patients, then we consider that the PPA itself is successful, and then we have to, the patients is successful for BPA is when they can take off the vasodilator therapy. But when it's not achieved, then we have to determine the residual lesion of BPA, whether we have to perform the additional BPA or we just leave for vasodilator therapy. So basically, the several factors will affect the outcome of BPA. The first is indication, and the second is treatment goals. So the treatment goals actually for BPA is to relieve pulmonary hypertension, and then it considered complete when the patients are free of symptoms, they are free of pH-specific drugs, and they are free of home oxygen therapy. And the patients believe that they are no longer require additional BPA sessions that we decided. And we have to determine the disease characteristic itself, whether it's favorable or it's unfavorable. So there are several aspects that we should think. The first is the selection of the target lesions. So ideally, the lung perfusion scintigraphy is a guided, it's imaging that should guide our selection. When the right lung involvement and when the inferior lobe involvement is more, then it will be more suitable for BPA and the outcome is much better than when it affects the superior or middle lobes. And the lesion morphology guided selection base means that the segmental lesions where the type of the lesions of the thromboembolic itself from the selective pulmonary angiography will define the outcome of the balloon pulmonary angiography itself, angioplasty itself. So this is the schematic types of the lesion from the CT that actually it's a bit difficult if it's not the abrupt narrowing of the segment of the pulmonary artery, but CTAP itself has a quite wide variable of the lesions. So from CT we have in this A is a web lesion, and then this is the web and slit lesions, and then C is the only slit lesion, and then D is, I think, is the easiest type of lesion when there's a abrupt narrowing and then we lost the distal rand off. So this is also the CT that we can observe the slit type of the lesions. But actually, if we do the more selective pulmonary angiography, there are quite a variable type of lesions that should be considered for CTAP, and then we should think whether the favorable lesions for BPA or not. For example, the A, this is from the right middle segment of right pulmonary artery. Then we can see there's a ring-like stenotic lesions. And then this type of B is quite difficult to observe unless we do a very selective pulmonary angiography, and it's usually non-observable from the CT scan. And B is the web lesion, and this is quite obvious that this is subtotal occlusion, and then D is total occlusion, or we call it like a pouch defect, and E is where the lesion is quite tortuous.
Dr. Wulan, sorry to interrupt, ma'am. We have running out of time. Kindly.
Okay, so I'll be fast. So this is the most important that we have to classify angiographically as published by the Japanese, that ring-like or the bands-like and the web lesion is the most favorable for balloon pulmonary angiography, while the subtotal lesion we still can do because we can see the lumen. But the total of the pouch defect and the tortuous lesion is it's not favorable for BPA because it has a very high risk for failure and perforation and also bleeding. And second is the multiple sessions. What it means is by that for each patient we should do in small numbers of the segments and not do lots of segments in once because of the risk for the perfusion pulmonary edema injury. And we also have to consider that the radiation exposure, and generally each patient will require 3 to 6 sessions. Technically it will be similar to the coronary, but we have to be cautious that structurally the pulmonary artery is much different from the coronary artery. So we have to use the soft and floppy tips like the workhorse wire, and then we can use any kind of the guide catheter like a MP guide catheter or the GR, which is suitable for the segments of the artery. So what it means by stage multiple lesions, and we also have to be cautious that we don't have to make it perfect as we do in coronary PCI. Because once the post-BPA, usually there's a residual lesion, but 1 month or 2 or 3 months post-BPA, we will see the very good flow to the peripheral. The next is we have to assess the pulmonary grade flow scores, and it comes from the 0 to 3, when it goes to complete perfusion of both pulmonary arteries and veins, then we will have a good result of BPA itself. And regulations. And the first one is we have to get a pulmonary flow grade 3. And some people will use the pressure wire, like we have the FFR more than 0.8, but most of the people will not use the FFR to evaluate. And we should have the mean pulmonary artery distal lesion should not exceed 35 millimeter mercury, because it will result in the risk for reperfusion pulmonary edema. And we have to also be cautious for the this risk, because it comes quite a lot when we become quite aggressive of doing the BPA itself. So the outcome is for BPA is quite good based on the multinational center registry in Japan, that it will improve the functional class, 6-minute walking distance, the anti-pro-BNP, and also the PVR itself. So as a conclusion, the treatment options for chronic pulmonary hypertension are evolving, including the endovascular therapy for CTAP, and PE actually is still gold standard, but balloon pulmonary angioplasty may be considered as an important therapeutic option for patients with CTAP who are not amenable for PE, with promising results. And recently, with the development of technical of BPA, they have a low complication rates.
Thank you very much, Wulan. That was great. And as it is, I know you come from a teaching and professor's family, so everything is very well documented and academic in your presentation. I really congratulate you for the good program you're going to start. And we have started at our center doing the CTPH angioplasties, but hopefully, maybe because the cases are not many, we can probably collaborate and we have some registry for Southeast Asia. That was
right, because the difficulty is in diagnosis.
Yes, that is the main thing, the diagnosis and how do we actually pick up these patients. In India, it's very important also, unlike in Indonesia, patients have to pay out of their pocket, and these are very chronic patients and who have already deployed all their funds. But nevertheless, it was great, and this is good that you are starting this program. We just started about a few months back in Delhi. I believe we are the only center in the country who's doing it as a regular program, and hopefully we will be able to share our results in the next week. Thank you very much, and I know it must be midnight in almost.
I'm looking forward.
What is the time in Indonesia?
11 p.m.
Yeah, it must be almost midnight. So thank you very much for staying on and attending APVIC. And please,
very much, sir.
All the Indonesian faculty. We also have an Indonesian session on, I think, on Monday or Tuesday. And Dr. Duni Firman, he was there chairing Dr. He was there yesterday chairing Greg Stone's talk, and he would again be there on the Indonesian session. We hope to enjoy it. Convey my regards to all your Indonesian colleagues. Stay safe. And my regards to Rini. Thank you so much. Now,
thank you so much.
Second speaker would be Dr. I think, let me invite Dr. B.C. Srinivas. He is a very close friend, now the Secretary of Indian College of Cardiology. He does very good work. We have equal passions in central vein recanalization. And we just had Dr. Manjunath speaking and giving a wonderful lecture yesterday. And now we'll have Dr. Srinivas Kumar. We need to listen for another 10 minutes on a wonderful lecture on central vein occlusion and recanalization. So, BC, over to you.